Good afternoon. All the viewers are welcome in our teleconferencing program. Today's program is jointly conducted by Indira Gandhi National Open University and National Board of Examination. Today we will talk about anemia, and for that purpose we have with us in our studios some experts. I would like to introduce you. First of all, Dr. Renu Saxena, Professor and Head of the Department of Hematology, All India Institute of Medical Sciences. Dr. Hariprasad Pati, Professor in Department of Hematology, All India Institute of Medical Sciences. And Dr. Manoranjan Mahapatra, Associate Professor, Department of Hematology, All India Institute of Medical Sciences. You all are welcome in our studios. Now, I would like to introduce the topic of today's first session. The first session is about lab approach to anemia, and to tell us about this particular topic, I would like to request Dr. Renu Saxena. Dr. Saxena, kindly throw some light on this.
Yeah, thank you very much. At the outset, I would like to say that anemia is one of the most common presentations that we get of various hematological disorders. And that's the reason we took up this topic to talk on anemia today. So I'll be talking on how we can clinically suspect the various kinds of anemias and how a laboratory helps in identifying or differentiating those kind of anemias. So I'm going to talk on approach to anemia. Now, before we go on to the approach, how do we diagnose anemia? Two important things are hemoglobin estimation and hematocrit. Hemoglobin is various levels have been given by WHO for saying below what is anemia. These are the levels that have been given in pregnant women less than 11 grams per liter, non-pregnant women less than 120 grams per liter, men less than 130 grams per liter are the various WHO cutoffs that you want to follow. Based on the level of hemoglobin, it can be classified into mild, moderate and severe anemias. And here again, as per WHO, severe is said when hemoglobin level is less than 7 grams per deciliter, moderate between 7 to 9.9 grams per deciliter, and mild when it is more than 10 grams. Just briefly about the methods for estimation of hemoglobin. There have been a large amount of methods that are available, but the most commonly followed method is calorimetry, which is a gold standard. Earlier, Sali's method used to be followed, and now with more and more automation coming up, it is the automated counter which is the preferred method of estimation. This is the Sali's method. I will not go into the detail, but it's important to know this is not a very sensitive and a reliable method. So really it's not something to be followed. Drapkin's method or Steinmetz hemoglobin method is a fairly good and sensitive method, only it takes quite a bit of time. And so automated counters, which are not only sensitive but specific, also they are much easier to operate, and they give, in addition to hemoglobin, a number of indices as well, which throw light on the type of anemia. As for hemoglobin, we also have normal cutoffs for hematocrit by the WHO. If we come to the causes of anemia, they can be broadly classified into decreased production, which can be due to any of these causes, or increased loss, which can again be due to any of these causes. So based on the kind of symptoms and based on the kind of lab examinations, you can conclude what is the exact cause of anemia. So when we see that a patient comes with pallor and signs and symptoms of anemia, you want to know whether there is associated fever or associated hemorrhage or not. So if you know that there is fever and hemorrhage, you look at the duration of all the symptoms. If the duration of illness is short, you look at the spleen. If the spleen is enlarged, you can consider diagnosis like acute leukemia and tuberculosis. But if the spleen is not palpable, you can think in terms either of an aplastic anemia or an early form of acute leukemia. On the other hand, if the duration of illness is long, again you look at the spleen, whether how much palpable it is. If it is massively enlarged and the patient is coming from an endemic area, then you will consider it could be a Kala Azar or a malaria, these two infections. On the other hand, if this patient is not from an endemic area, then you would like to consider some of the other diagnoses like myelofibrosis, hairy cell leukemia, CML, CLL and NHL. I'll come to these a little later. On the other hand, if you have mild to moderate spleen enlargement or no spleen enlargement, then you look into histories of loose motions, diet, intestinal surgery, etc. And if this history is forthcoming, you would like to think of megaloblastic. But if there is no such history, you want to exclude things like paroxysmal nocturnal hemoglobinuria and NHLs. On the other hand, if you find fever and hemorrhage are present and it is of long standing duration and spleen is not palpable, then you again take history of diet, intestinal surgery, etc., which if you find it, it is suggestive of a megaloblastic anemia. But if you don't find it, you find is there history of passing of red urine, is there history of thrombosis anywhere? If that is present, then that's suggestive of a PNH. Otherwise, you would like to consider diagnosis of myelodysplastic syndrome, which will be elaborated in the next talk. And then you have anemia without fever and hemorrhage. Here again you look at the duration. Is it of recent onset? Is it since birth? If you find that this kind of a history is of a recent onset, see whether jaundice is present or not. If there is marked jaundice, consider autoimmune hemolytic anemia. If there is a mild jaundice, you can still keep a diagnosis of megaloblastic anemia or a paroxysmal nocturnal hemoglobinuria. If there is no jaundice, then look for history of bleeding, look for diet, look for loose stool, because then it could, if this history is present, it could either be a nutritional anemia in the form of iron deficiency or megaloblastic. But if this history is not present, you'd like to keep refractory anemias as the underlying diagnosis. However, if the anemia is present since birth and you find that there is marked jaundice, then look further. Is the jaundice precipitated by drug or infection? Then one will consider a G6PD deficiency. Is there associated dactylitis or fracture femur or a malarial parasite? See if then that will point towards a sickle cell disease. See if the family history is positive, spleen is enlarged, then hereditary spherocytosis. If there is no jaundice, you would like to keep a possibility of pure red cell aplasia clinically, but we have to confirm all this on the lab. On the other hand, if there is minimal jaundice and liver and spleen has to be looked at, age of presentation, severity of anemia, transfusion requirement, and the region from where the patient is coming. If there is small liver and small spleen, but there is severe anemia and the patient is from West Pakistan, you would think in terms of a thalassemia major. If it's a young adult, moderate anemia from Bihar, Gurkha or Assam region, you can think in terms of thal intermedia, maybe secondary to HBE disease or HBE thalassemia. If it's an adult with mild to moderate anemia, thalassemia intermediate to minor, you would want to keep in mind. And if none of these are present, then congenital dyserythropoietic anemia is what you'd like to consider. But all suspicions of clinical have to be justified and have to be actually confirmed on lab. So in addition to hemoglobin estimation, you would like to look at the red cell morphology and also whether the reduced hemoglobin is associated with changes in TLC or platelets. Basically, based on red cell morphology, we can have three kinds of anemias: microcytic hypochromic, where the cells are like this, very marked hypochromia and small in size; macrocytic, where the cells are large; and normocytic normochromic, where the central pallor is 1/3 of the whole red cells. So when we come to anemia with normal TLC and the red cell morphology is normocytic normochromic, it's important to first look at the reticulocyte count. If the reticulocyte count is normal or reduced, a bone marrow aspirate needs to be done. And if bone marrow aspirate is normal and you look into further and find is there a renal cause or a chronic disorder underlying it, or there is a liver disease or a refractory anemia. But if there is erythroids which is less than 4%, then it is pure red cell aplasia. On the other hand, if reticulocyte count is slightly increased, paroxysmal nocturnal hemoglobinuria is to be suspected. But if the reticulocyte count is markedly increased and there is normocytic normochromic red cells, then a G6PD test needs to be done. If the G6PD test comes out as positive, that is absolutely diagnostic of a G6PD deficiency. If it is negative, look into the peripheral smear also, and if you find spherocytes over there, then that is suggestive of a spherocytic kind of a hemolytic anemia, which can be again two types. So you can do a Coombs test to see what is the result. This is a Coombs test, and as you can see here, you can see there is a positive line here. So a positive Coombs test means the anti-IgG antibodies are present. That will make one suspect of an autoimmune hemolytic anemia. Coombs test is negative, family history is positive, then that suggests a hereditary spherocytosis. We come to a macrocytic anemia. Look into the peripheral smear and see are there presence of macrovellocytes, hypersegmented polys, and look into the bone marrow. If you see megaloblasts present like here, if you see hypersegmented polymorphs, that's absolutely diagnostic for megaloblastic anemia. But if these things are not there, do a reticulocyte count. Here again, if retic count is normal, look into other causes like liver disease, myxedema, and refractory anemia. But if retic is increased, you can think either in terms of a treated megaloblastic or a hemolytic anemia. We next come to anemia with normal TLC and microcytic hypochromic red cell picture. Again, important thing is reticulocyte count. If the reticulocyte count is normal, then do a serum iron. If the serum iron shows that it is reduced, look at the TIBC or the total iron binding capacity. Now, if you find that the TIBC is increased, this feature is highly suggestive of an iron deficiency anemia. But if you find that TIBC is low, that is suggestive of anemia of chronic disorder. For both these cases, one can resort to a bone marrow iron, which will be absent in iron deficiency anemia and increased in chronic disorder anemia. On the other hand, if you do serum iron and that is normal, then you would like to consider sideroblastic anemia, and this can be confirmed on looking at ring sideroblast on a bone marrow iron stain. On the other hand, if the reticulocyte count is high with a microcytic hypochromic picture, you would like to keep in mind hemoglobinopathies, iron deficiency anemia on treatment, congenital dyserythropoietic anemia. So look at the history of iron therapy. If there is a history of iron therapy, that is iron deficiency on treatment. If there is no history of iron therapy, look at the red cell morphology and see what kind of anisocytosis is there. If it is a mild anisocytosis, you need to exclude thalassemia minor, which can be done by doing a hemoglobin A2, which is between 2 to 9% in thal minors. This is one of the ways by which HbA2 can be done using an HPLC. As you can see, this is a raised HbA2 level over here. But we come to the situation where there is microcytic hypochromic red cell picture with marked anisocytosis. Here it's important to do HbF levels, and they can be either markedly increased or they can be mildly increased or they may be normal. If they are markedly increased, we look at the age of the patient. If it is a child, then it could be either a thalassemia major or an HPHS or hereditary persistence of fetal hemoglobin. So here we can confirm it depending on the hemoglobin. If the hemoglobin level is markedly low, it is like a thalassemia major, we can confirm on doing HPLC and looking at HbF levels, which will be high, and in the parents HbA2 levels will be high. On the other hand, if the patient is an adult, we would like to think in terms of a thal intermedia presentation of hemoglobinopathy. If there is a mild elevation of F, then you would think in terms of hemoglobinopathies. So what are the various hemoglobinopathies that you would want to think? You will do HB electrophoresis, and it can be either in HBE disease as is seen in Assam, it could be HBS disease or a HBD Punjab, and you can differentiate between the two using a sickling test. If sickling test is positive, that is HBS disease or sickle cell. If it is negative, it is a HBD Punjab. D Punjab is commonly seen in Punjab and HBS is seen in various pockets of India and tribals. Also look at the HB level, electrophoresis level. If it is normal, then you would like to consider congenital dyserythropoietic anemia, which can be confirmed on the bone marrow and doing a HEMPAS test. Typically, this is what a peripheral smear can give a clue to, typical sickle cells seen in sickle cell disease. This is what a peripheral smear looks like in beta homozygous thalassemia. You see microcytic teardrop cells, target cells. This is what one can get on hemoglobin electrophoresis, and this can be performed either on an agarose or a gel, agarose gel or a chromatography paper, and this is a site of application. This is where HbA2 and E elute. This is where S, D, G and Q India come. This is where F, this is the normal adult hemoglobin, and these are the fast moving hemoglobins. You can also resort to HPLC. As you can see, this is the normal HbA, this is where the HbF retention time comes, and this is where HbA2 comes. This is a case with homozygous thalassemia, where you can see there is virtually very little A, almost zero, but look at the HbF, which is quite high, and this is where A2 comes. We next come to the group where anemia is there associated with pancytopenia. When this is the kind of picture, again we look at the red cell morphology because it gives us a clue. If we find it is pancytopenia, anemia and microcytic hypochromic cells, it could either be a PNH or it could be a combined megaloblastic and iron deficiency. On the other hand, if we get a macrocytic kind of a picture, it could be either a megaloblastic anemia or a myelodysplastic syndrome, and you can differentiate between the two. Give therapeutic trial of vitamin B12 folic acid. If the response occurs, it is megaloblastic anemia. If it does not occur, it is a myelodysplastic syndrome, but we will talk about MDS a little later. It's equally important to know how to exactly perform the therapeutic response to B12 folic acid, and it is important here to say that B12 and folic acid will be given to the patient, and peak reticulocytosis occurs between day 5 and day 8 after giving B12 folic acid. So a repeat reticulocyte count needs to be done at this point of time. Now this is a picture which is showing one category of myelodysplastic syndrome, which will again be discussed in detail shortly, showing you refractory anemia with excess blasts. We next come to anemia and pancytopenia, but normocytic normochromic red cells. Here again we resort to a reticulocyte count. If the retic count is high, then do PNH tests. Typical PNH tests are Ham's tests and sucrose autolysis test, but now we have a gel card test which is also very easy to characterize, and it actually picks up CD55 and 59 deficiencies. So if the PNH tests are positive, it is a PNH, but if the PNH tests are negative, look into the bone marrow. You might just be able to pick up, if there is a hypersplenism present, you might be able to pick up LD bodies, or it may be a tuberculosis. If these are not there, you again want to consider MDS. If retic count is less than 1%, do a bone biopsy. It could be either myelocytic, that means there is something infiltrating a metastasis in the bone marrow, or it could be an aplastic anemia where there is virtually no cells in the marrow. And then we come to this condition where there is anemia with a very high total leukocyte count. It's important here to do a peripheral smear examination. It could be either an acute leukemia or a chronic lymphocytic leukemia or a non-Hodgkin's lymphoma. It could either be CML, either in a blast crisis or a myelofibrosis phase, or it could be a myelofibrosis per se. Now this is what you would get on a peripheral smear in a leukemia. You will get cells which have large nuclei, very scant cytoplasm, which may or may not have granules in them, and there may or may not be an R-rod. So it's important to know this is acute leukemia, and then you have to resort to morphology and cytochemistry to be able to differentiate between ALL and AML, because the two have different treatment patterns. In ALL, you will see 1 to 3 nucleoli, unlike AML where you get more than 3 nucleoli. Chromatin will be coarse in an ALL vis-a-vis an AML where the chromatin will be very fine, and R-rod and granules will be present in an AML blast. You can further resort to cytochemistry. Sudan black can be performed. Sudan black is a stain which is lipophilic, and it is positive in AML and negative in an ALL. You can also resort to myeloperoxidase, which is again positive in AML, negative in ALL. You can resort to also non-specific esterase, which will be positive in acute monocytic leukemia but negative in ALLs. Chronic lymphoid disorders. Here it's important to know that chronic lymphocytic leukemia can be one kind of a presentation. The type of presentation, this will have very high TLC will be there, and most of the cells in the blood will be mature looking lymphocytes. You may in between have these slightly immature looking cells which are pro-lymphocytes. In a typical CLL, you will have less than 15% of pro-lymphocytes. You have a CLL, PLL syndrome where you can have pro-lymphocytes between 15 to 55%, and then you can have a pro-lymphocytic leukemia where predominant cell type more than 55% is these pro-lymphocytes. So in addition to these features in a CLL, you will also get what we call as basket cells, which are degenerating cells. All this will make you suspect a CLL. However, you still will not be able to differentiate between a CLL and a mantle cell lymphoma with SPIL, and so here you need to resort to a flow cytometry, which will help you differentiate. On flow cytometry, it will be found that CD5 and 23 are positive in CLL, and in mantle zone lymphoma, CD5 will be positive, but CD3 is not positive. The another case where you may get anemia with very high TLC could be CML. Typically CML in chronic phase does not have very severe anemia, but what you get in CML is a high TLC. You will get all maturing cells, you will get basophils, you will get neutrophils like this, you will get metamyelocytes showing indented nuclei, you will get myelocytes showing a single nucleus with granules in the cytoplasm. So when you see all these kinds of cells, it will be CML chronic phase. But if you get blasts which are high in number, more than 20%, then it will be CML blast crisis. More than 10, you will suspect CML in accelerated phase. And so I would like to conclude here that laboratory plays an important role in the diagnosis of anemia. And it's important for this to have correct hemoglobin estimation, a good red cell morphology interpretation, and facility of having a lot of ancillary tests and bone marrow interpretation. Thank you very much.
Well, Dr. Renu Saxena, you have told us in detail about the lab approach to anemia, but some questions are still in my mind. If you allow, I will ask you.
Yes, please.
First of all, I would like to ask you that which is the most common cause of anemia?
Yes.
Anemia is very prevalent in India.
Anemia is actually seen in almost 80% of population of India, and the commonest deficiency is nutritional deficiency, of which the most common is iron deficiency anemia. And this is particularly more common in women, and this could also be because of the increased menstrual flow that they get, and also the diet. One of the important causes of anemia in field is hookworm infestation, because the farmers are often barefoot.
And how can one get rid of anemia?
Well, anemia has to be treated. If it is a nutritional anemia, then iron deficiency, if we can identify, then iron needs to be given to the patient. We have a whole session on management of anemias following up. And if it is a megaloblastic anemia, then folic acid and B12 can be given. Between the two, folic acid is more common because folic acid stores are lesser in the body. They last for about 3 to 4 months only, unlike the vitamin B12 stores which last for 5 to 6 years. So that is more common seen. And if it comes out any other cause, then specific treatment needs to be given for them.
What would you like to tell our viewers about the diet? Which specific things should they take that they can be?
Yeah, actually iron is very rich in fruits like chiku, papaya, figs, raisins. Iron is these are all good sources of iron. Okay. It could be green leafy vegetables. So all these can lead to good source of iron. Vitamin B12, folic acid, again green leafy vegetables, meat, all these things are good sources.
Okay. And how does a patient suspect that he or she has anemia?
The patient will feel weak. All the normal activities which the patient was earlier able to do, now he finds he gets fatigued very easily. Quickly he gets tired. He may be developing pallor, which means his skin will become more sallow. And if he is climbing, he will quickly get breathless. So he tires very easily. There may also be a component of irritability. He may quickly get irritable also.
And you talked about the thalassemia in
Yes.
your discussion. Then how common is thalassemia and how do you suspect it?
See, thalassemia is there is thalassemia minor and thalassemia major. So thalassemia minor is the heterozygous or the carrier forms of thalassemia. In Delhi, it's seen in as much as 12%. In India, it varies between 5 to 12% in various areas of India. And thalassemia major, you have to be very careful. It's more often seen in migrants from Punjab. So you get it in Punjab. You can see thalassemia major because of beta homozygous thalassemia in Bihar, in eastern UP, in Nepal area, and in HBE thalassemia you get more often in Assam, Odisha. So there are definite pockets. So when do you suspect a beta homozygous thalassemia? If there is a child who's been coming progressively increasing pallor since birth, there is a hepatosplenomegaly which is increasing and he is requiring transfusions to maintain his hemoglobin. So that's important to suspect it could be a thalassemia, and you go into the family history. Are they migrants from West Pakistan? Are they from Punjab? And you find that both parents are like that. Is there a family history of another cousin also having a similar kind of a thing? That is another suspicion towards a thalassemia. So thalassemia can be diagnosed like that, and management, of course, as I said, we are going to have a whole session on it. But what's important is that since the management is quite cumbersome, now more and more people are talking on control of thalassemia as well. And control of thalassemia can be done by doing good screening for carrier status, and then a pregnant woman can be antenatally screened, especially if her husband is also a thalassemia carrier. And then the patient, the mother can be antenatally screened, and prenatal diagnosis can be performed using molecular tests. And then if you can prenatally diagnose thalassemia, the option to abort exists.
You have told us that Punjab, Bihar, Eastern UP and Nepal are more prone to thalassemia. Is there any specific reason for being so regional for this thalassemia?
See, the thalassemia gene is supposed to have immigrated from Mediterranean areas. And as the Mediterranean armies came across all these areas, there was inbreeding, and because of that there was a transmittance of gene to these areas particularly. So if you see, it follows the path of migration of the Mediterranean armies that came long time back.
Does the genetic factor also work in this or not?
Oh yes, this is completely genetic. This is thalassemia is like an autosomal recessive, and that's why inbreeding leads to a lot of thalassemia. It's autosomal recessive.
Which is the main age group for the thalassemia patients?
See, thalassemia major normally occurs in young children only. But if it is of a milder variety, then they are not picked up so early. So then it comes up in young adults, and that's called as thalassemia intermedia.
In infants too?
Yes, in infants also it comes.
Okay, and what about the senior citizens?
No, senior citizens no. If they can have thalassemia minor. This is genetic. So whatever is there is present since birth only. So if it is genetic, then whatever is there in children, it will come as major. Most of the time, if patients are not treated because of iron overload, they actually do not survive for very long. And so in old people, senior citizens, at best you can get a thal minor kind of a presentation.
You have told us that blood transfusion is the only method for its treatment. Then are there any risks related to this particular blood transfusion in thalassemia?
See, transfusion has a number of risks. One is that repeated blood transfusions can lead to iron overload. Iron overload itself can cause a number of complications in thalassaemic children. The other is the transfusion transmitted infections. Common transfusion transmitted infections are the HBS, malaria, HIV. These are three very important. HBC, HB. So